Welcome everyone. A very good morning to all our participants. Let us just wait for a minute or two for the audience numbers to rise a little bit. I hope all of you are having a good Sunday morning. All loaded with breakfast, ready for the session. Yes? All right. Now, as we all know, the world and our country especially is still gripped by the pandemic. And now it has got personal. Either we know 10 others who've got the coronavirus, or we have been infected with it ourselves. Or worse, we have faced personal losses in terms of death. And it doesn't end here. Post-COVID recovery also, dangerous effects are being seen in the oral cavity, especially like fungal osteomyelitis or mucormycosis. So in such a situation where the world is still reeling under the effects of the virus, what is our professional role as a dental surgeon? Firstly, our role is to understand the difference between being vigilant and being panicky, to know all the facts, and then to help our patients as much as we can. So to help us understand this difference and help us serve our patients better, we have with us today 3 experienced and globally trained dentists in this very special live session by DentalReach, speaking on the effects of COVID on the oral cavity. I am Dr. Nupur Shrirao. I'm a prosthodontist and your moderator for this session. And it gives me great pleasure to welcome our panelists today. Our first speaker, Dr. Vinay Kumar. Sir, can we please have you on screen? Dr. Vinay Kumar, sir. Please, can you switch on your camera?
Good morning, all.
Hello, sir.
Hope you can
see me. Good morning.
Have a great Sunday.
Yes, you're visible. Thank you, sir. Dr. Vinay will talk about oral manifestations of COVID. We then have a combined session by Dr. Anjan Shah and Dr. PC Jacob. Dr. Anjan, hello, sir.
Morning, everyone.
Dr. Anjan is also an oral reconstructive surgeon who will talk about the surgical management of these manifestations, and the prosthetic management will be covered by Dr. PC Jacob, sir. Jacob, sir, who is a maxillofacial prosthodontist. Can we have you on screen for a small hello?
Hi, everyone. I hope you're having a good Sunday, and please have a great webinar. Thank you.
Great. Warm welcome to our respected faculty. At the end of the session, we will throw open to the audience for questions and answers. So let us begin now. Our first speaker is Dr. Vinay Kumar. Dr. Vinay did his master's in oral and maxillofacial surgery from Nair Dental College, Mumbai, and his DMD from Gothenburg University, Germany. He then got his fellowship in dental surgery of the Royal College of Surgeons, Edinburgh, and is MD and PhD from Rostock University, Germany. He is currently the adjunct faculty at Uppsala University Hospital, Sweden, and Amrita School of Dentistry, Kochi. He is also a consultant at Sri Shankar Cancer Hospital and Research Center and the director of Oral Rehabilitation Center, both based in Bangalore. Dr. Vinay, honored to host you. I request you to please begin our session.
Your mic, Vinay.
Thanks, Nupur. Thanks for the nice introduction. And I hope you have a nice Sunday. I was asked to discuss on oral manifestations of COVID-19. And the outline of the lecture would be I would introduce the topic, discuss a little bit of oral manifestation of COVID-19, then discuss on opportunistic infections, especially invasive fungal infections, post-COVID recovery, and a few tips perhaps on how we can do dentistry during COVID. So as we all know, I think there's no human being on earth who has not been affected by the coronavirus disease 2019. And it's just not been short. It's been over a year and a half. And this virus transmits from human to human transmission. And worldwide, over 15.6 crore people have been directly affected by the disease. And India, over 2.15 crore, and the numbers are rising. The most common symptoms are fever, cough, shortness of breath, dysosmia, difficulty to smell, and dysgeusia, the difficulty to taste. About 80% of directly infected patients are mild. 15 patients have the severe symptoms, and 5% of these patients require intensive care with ventilator support. So the coronavirus, the virus that causes coronavirus disease 2019 is a SARS coronavirus 2, and that invades human cells by a receptor called ACE2, angiotensin converting enzyme 2. This has been found by single cell RNA sequence data analysis. So all those cells who have ACE2 receptors, they form a host for the virus. And these cells are generally seen in the lungs, pancreas, in the colon. You have some in the heart. But more for us as dentists, more importantly, there are many ACE2 receptor cells seen in the tongue and the salivary gland. So there is a role between COVID and the oral cavity because the cells of the oral cavity form a host for the COVID virus. When you check oral manifestations of COVID and you do a PubMed search or a Google image search, a wide variety of lesions come saying that they are associated with COVID. Like the geographic tongue, you have non-specific ulcers, you have vesiculobullous lesions, petechiae, desquamated gingivitis, infections like candida. You can have white lesions all over the mouth. And it's just not limited to one organ, but it's seen in the tongue, in the palate, in the lips, in the gingiva, in the buccal mucosa. And early on in 2019, we had this very popular article which was spread around saying that perhaps tongue and skin lesions on the toe can be the first symptom of COVID-19. And so tongue lesions could be early symptoms of the disease. But over a period of time, when we look at other researchers have gone in and seen oral lesions, they say that in mild cases, oral mucosal lesions develop before or at the same time at the initial respiratory symptoms. So there could be some percentage of patients who could have a prodromal symptom showing some kind of an oral lesion. However, those who required medication and hospitalization, the lesions developed approximately a week to 24 days after onset of symptoms. And then now the current opinion is that oral mucosal lesions are more likely to present as a co-infection or a secondary manifestation because most of these patients have multiple clinical aspects. Some of them are debilitated by other ways. and so on and so forth. So it's not a direct manifestation of the COVID virus in the oral cavity. It's more likely to be secondary. We must also understand that most of these data that come talking about oral lesions are like cross-sectional data of in a center, in a large COVID center. Say, for example, in this study, there were 666 patients admitted in a field hospital in Spain. And these dentists and dermatologists went and took a cross-sectional study and checked all the oral cavities and then wrote down the features. And so it's a cross-sectional study seen in a camp, which need not necessarily be related to a clinical setting or a longitudinal setting where someone comes in with this and then followed up over a period of time through the disease to see how it has spanned out. So we don't have really longitudinal kind of studies, barring a few case reports. If you would like to know more about oral manifestations of COVID-19, I would suggest you seriously to read this article from Journal of Dental Research. It's a clinical review. And now PubMed has made available most literature regarding COVID freely accessible. So you don't need to be a part of a university library. You can access most of it by yourself. And then this is a living systematic review. And what that means, what the authors intend to do is that if you can see a small orange circle, there's a box called check for updates. And the authors, they want to update more new information as and when it comes. It's a different thing that the last time it was updated was February, but I think they have an intent of keeping on updating this literature. So that's why they call it as a living systematic review. You would like to read this article if you want to know what are the oral manifestations of COVID. But barring mucocutaneous lesions, the most common oral manifestation of COVID is gustatory manifestation, that is taste manifestation. And that's seen in about 45% of the patients. 38% have some form of dysgeusia, which means that their taste is not the same. They can't taste like how they tasted before. So wine can seem like chocolate and things like that. Hypogeusia is when you have a decreased taste sensation of the same amount. So the intensity is much lesser. And 20% of patients have ageusia. They can't taste anything. And so that's a very common oral manifestation. And this taste disorders have been significantly associated in patients with COVID. So if you compare patients with COVID and patients having symptoms like COVID, but without the SARS-CoV-2, coronavirus 2, if you compare patients with same symptoms, but not the same infective agent, there's a far lesser gustatory manifestation in patients without COVID as compared to patients with COVID. So that is clear, that COVID has got a clear manifestation with taste disorders. And what's interesting is that females have had a greater affliction towards taste disorders as compared to males. So what causes this? Why does COVID, SARS-CoV, coronavirus 2 cause taste disorders? There are a few hypotheses. It's not proven, but they are all in a hypothesis stage right now. First one says that, local inflammatory responses from rhinitis. So your nose is blocked and that here hampers taste buds, but not necessarily. There are patients who can have a clear nose and they still cannot taste well. Taste disturbance has a concomitant olfactory disorder. So you have both taste and nasal smelling problems. But again, that's not corroborated in all the patients. And they say that SARS-CoV coronavirus 2 with gustatory components and ACE2 receptors, they have an interaction, and tongue has ACE2 receptors. So the gustatory components and ACE2 receptors are kind of combined together. They are very near each other, and tongue has ACE2 receptors, and perhaps that's the reason why you have taste disorders. It's still in the hypothesis stage. Of course, lots of people are working on it. So the take-home message on oral manifestations of COVID are that the taste disorders are easily recognizable, and probably that's an early manifestation of COVID. So if you have patients ringing up saying that I cannot taste well or so, then you'd rather advise them to undergo self-isolation as early as possible and then go for testing. Other oral manifestations they are most likely a secondary feature and they are not associated with the disease per se. But since there are a certain prevalence of these oral lesions in COVID patients, so anyway, it's a good symptom to keep an eye for these lesions. And if at all they do have these lesions, you try and inform the patient by saying, there is a increased incidence in COVID patients. Perhaps you might want to get it checked. Then I come to the second and the more important part of this session, which this session is mainly about, invasive fungal infections post-COVID. Now, these fungi are really beautiful through the microscope. And invasive fungal infections are mainly opportunistic infections from Aspergillus species or Mucor species. Mucor is also called a Zygomyces species or Candida. And these invasive fungal infections, they become invasive when the immunity of the individual is low, or in cases of microangiopathy, some kind of a secondary underlying disorder. So in a normal, healthy adult patient, it's quite rare that they get the opportunity to become invasive into the human body. And the most common form of the most common fungi that affects post-COVID patients is Mucor, and they form a disease called as mucormycosis, or it's also called as zygomycosis. And there are 4 types or 5 types of Mucor. The rhinocerebral being the most common, which affects the nose, the sinuses, the palate, the oral cavity, and goes up towards the eye and then onto the brain. Then you have pulmonary mucormycosis, which affects the lungs. You have cutaneous mucormycosis, that's on the skin. You have GI, gastrointestinal mucormycosis, in the colon and in the intestine. And you have disseminated mucormycosis, which is basically a blood-borne mucor. So in order to diagnose, you have these fungi that you can see on the left-hand side of the screen. And the round ball is the fruiting body, and you've got a filament, and that filament you can see is aseptate. That means there are no breaks in the filament. There are no bars in this filament like a sugar cane. You have sugar cane, you have bars on the filament. This is rather smooth, like a straw. And aseptate fungi, that's the feature of mucor. If you have septate, they are more likely to be Aspergillus. And of course, the fruiting body of the Aspergillus is something like a sun, whereas this is like a ball. Anyway, they look quite beautiful under the microscope. Now, each form of these mucor, they are associated with a particular form of a pre-existing condition. So the rhino-orbitocerebral mucormycosis is very often associated with uncontrolled diabetes mellitus or diabetic ketoacidosis. The pulmonary and disseminated forms are associated with hematologic malignancies, patients who have got bone marrow transplantation, and typically this is very common in the West. Patients on bone marrow transplantation, patients who are immunosuppressive because they've got hematologic malignancies and they are under long-term care, they have these form of mucor. Whereas in India, typically you have the first form, the rhino-orbitocerebral. GI is in patients with malnutrition, in patients where the health condition is quite poor. Cutaneous comes in patients who have got burns or some form of trauma to the skin. And always to diagnose this, you need to have a histology or culture, and that culture the fungi, and that's the gold standard of diagnosis. Now, when you talk about mucor in India prior to COVID-19, so it's just not COVID-19 that has formed this lot of mucor cases. The fungi hasn't come in India just because of COVID. If you look at literature prior to COVID-19, in the year 2000 to 2004, this group from PGI Chandigarh, from the medical microbiome department, they reported 178 cases in 4 years. And in that, the rhinocerebral was most common. And this group has been reporting. They have a registry. So they have reported in 2014, they have reported in 2016, and so on. I've just taken one of the articles. So the rhinocerebral was the most common, affecting 54%, followed by cutaneous and followed by disseminated. And uncontrolled diabetes mellitus was the most common predisposing factor. So the odds ratio is 1.5:8, and there was no risk factor in about 11.8% patients. So most of them had diabetes mellitus. This is from the south. This is from Christian Medical College, Vellore, where they reported 184 cases in 10 years. And even in their report, rhinocerebral was the most common, and uncontrolled diabetes mellitus was the most common predisposing factor. So the other two were all about retrospective studies. So I wanted to get a prospective multi-center study on Mucor in India. So that means every time a patient with Mucor is coming for treatment, they record it and they put it up out there for others to see. So it's a prospective study, and they reported 388 cases, nearly 400 cases in 4 years. So about 100 cases a year were reported. This is prior to COVID. And rhinocerebral was most common, followed by cutaneous and disseminated, and of course, uncontrolled diabetes mellitus was a factor. So when you look at invasive fungal infections out of the reporting countries of the world, and I can imagine that there are many countries that don't report, their documentation is not so good. But among people who report, India is the Mucor capital of the world. And that's what I've taken it out of one of those articles from the author from PGI. So India is the Mucor capital of the world. We know that India is the diabetic capital of the world. We know that in India, you can have widespread and injudicious use of drugs, including antibiotics and steroids. So I can go to a pharmacy and I can get almost any drug that I want without having a specialist prescription, except for perhaps morphine. And there's a high level of self-medication. So there's this culture of not necessarily going to a specialist to medicate yourself. And so I think perhaps these are the reasons why post-COVID-19 it has really boomed. And I'm sure Dr. Anjan is going to talk about the cases and what are other predisposing factors, why he sees a boom in his practice, patients presenting with Mucor. Now, when I did a PubMed search for COVID and Mucor, and this is an article which is coming out of MD Anderson in Texas, and they say that their PubMed search for COVID revealed 7 papers in 2020 and 24 in 2021. More than 70% were from India. So even in the world reported literature post-COVID, 70 cases were from India. And uncontrolled diabetes mellitus, and many patients with diabetic ketoacidosis, most of them being on steroids, and that has caused this big storm of Mucor. This is an article in which had been published early this year, where the authors did a study between May to December. It's a retrospective case series of from May to December last year. They saw 18 cases of invasive fungal infections. Most of them were Mucor. There were some Aspergillus cases too. This is from Mumbai, where they talk about 6 cases between August and December 2020. And this is a case from the north, from PGI, where they talk about a case and a systematic review of literature, where they talk of Mucor-associated post-COVID, COVID-associated mucormycosis. So why do we find Mucor in patients with COVID? The causes are that most commonly it's seen in diabetics, and like in any other infection, COVID patients are predisposed to diabetics. So when a patient is under an infective assault, then the sugar level rises automatically, and so a pre-diabetic shifts to a diabetic, and perhaps a lot of uncontrolled diabetics shift to diabetic ketoacidosis. So that's common. So like any other infection, even COVID causes a diabetic shift. SARS-CoV coronavirus 2 induces damage of pancreatic islets, because pancreatic islets have the ACE2 receptors, and as we said that they are the host cells, so they damage these pancreatic islets, so decreasing insulin secretion. There's frequent use of corticosteroids, because I think if there's one class of drug that has shown to improve symptoms in COVID patients, and that's corticosteroids. So logically, you tend to prescribe corticosteroids for those patients. In patients with COVID, the ferritin and iron metabolism is not so well. So you've got high serum ferritin levels. So that gives a high level of iron in the microenvironment, which the fungus loves to thrive on. So the fungus loves this high amount of iron levels in the blood in that localized region. So it's conducive for the virus to grow. And endothelialitis, which is seen in COVID-19, as seen in autopsy studies that are seen in the background, where they've seen autopsy specimens where you have vascular blockage and you have some amount of fungi seen in these patients. So I would recommend if you were to inform your patients, maintain oral and nasal hygiene, avoid self-medication, routinely check blood sugar and HbA1c levels if the patient are already diabetic. If they are not, maintain check for blood sugar levels, and report immediately in case of dental pain, eye swelling or pain or bloody nasal discharge. And to practitioners, I would like to perhaps recommend that in diabetic patients diagnosed with COVID-19, please obtain baseline HbA1c and serum ferritin levels. Rationale the use of steroids. So perhaps have another thought whether you need to really give steroids. The role of antibiotics and antifungals. Refer to a multidisciplinary setting of OMFS, ENT surgeons, head neck surgeons, ophthalms, internal medicine, medical microbiome, prosthetic support, dental support, and so on. So make sure you send it to a multidisciplinary center. And perhaps you could advise for CT and MRI of the face and PNS to see how much of it is involved. Thank you for your patient listening, and I hand it over to my colleagues, Dr. Anjan and Dr. Jacob, please.
Thank you, Dr. Vinay, for your talk.
Welcome.
Dr. Vinay had an emergency night duty all night, and he has presented so nicely now in the morning. So thank you, sir, for sacrificing your sleep.
My pleasure. Thank you.
I'm sure the audience, it'll help them diagnose problems early now in our cases. Next, we have Dr. Anjan Shah, Dr. PC Jacob. Dr. Anjan did his master's in oral and maxillofacial surgery from Naya Dental College, Mumbai. He has trained and worked in Southampton University, Sheffield University, and Ipswich Hospital, all in UK. He holds 4 fellowships, 2 from the English and Irish Royal Colleges, and 1 in implantology. He also is the first fellow of the International Board of Oral and Maxillofacial Surgery to hold a Certificate of Added Qualification, or a CAQ, in oncology and reconstruction. Dr. Anjan is a professor in the Department of Implantology at Raja Rajeshwari Dental College and a consultant at Bhagwan Mahavir Jain Hospital, both based in Bangalore. With Dr. Anjan, we also have Dr. PC Jacob. Dr. Jacob completed his master's in prosthodontics from Annamalai University, Tamil Nadu. He's a certified maxillofacial prosthodontist from UCLA, mentored under Dr. Bumer himself, and is currently a professor in Vedahi Institute of Dental Sciences, Bangalore. Dr. Jacob is a consultant at Mazumdar Shaw Medical Center and Aster Hospital, both based in Bangalore, and is also the country representative to the European Prosthodontic Association. The audience, after this session, we will start taking your questions. Request you both, Dr. Anjan and Dr. Jacob, sir, to please begin our last lecture.
Thank you, Nupur. If we can just have the slides put up. So good morning, everyone. I think my video is just frozen. I'm just going to... I think thank you, Vinay, for having covered most of the theory about manifestations of COVID and post-COVID problems. Now, what me and Dr. Jacob are going to do are going to talk more about clinical stuff. And, till now we've seen some pretty pictures of fungus. Now we'll see what it looks like in the mouth. One of the things that I think we all need to remember is that what we have seen till now, the oral manifestations of COVID, especially things like fungal osteomyelitis, is just the tip of the iceberg. See, a lot of patients still haven't come to us because they're still afraid to come into hospitals, into practices, or they don't even know that such a thing as fungal osteomyelitis or fungal sinusitis exists. So I think we are probably going to see a lot more, but we'll show you examples of some of these that we've seen. Secondly, the thing to remember is that we've only been treating these patients for the last 1 year. See, we didn't know that COVID existed before March 2020. So most of these patients that we present haven't been, their treatment hasn't been completed, in the sense that, see, as dentists, it's not just treating the osteomyelitis. Obviously, that's the important thing, but it's also rehabilitating these patients back to being able to swallow, speak, and chew. These are things which sometimes we have to postpone because of the current, situation with COVID. So a lot of these patients haven't been rehabilitated. So during the presentation, what we'll do is we'll show you examples of how we've treated some of them and rehabilitated some of them, but other examples of how we could treat some of them. Now, me and Jacob both work together at a few hospitals, and I'm a resective and reconstructive surgeon, and Jacob rehabilitates most of our patients who require maxillofacial rehabilitation. So the examples that you see are all patients that we've treated both together. Some of them are post-COVID, some of them are not post-COVID, but I think it hopefully illustrates the case. So Jacob, anything else you wanted to add in before we go on to the cases?
No, I think you've summarized it well. I think we can go ahead with the cases.
So, okay, so just illustrating the first patient that we have. This patient came to us with a history of pain in the upper jaw. He was 36 years old, fit and well, not a known diabetic, but the only positive history he gave was that he had been treated for COVID 5 months ago. At that time, he was admitted for 3 days. He'd been treated with steroids, and he'd made a fairly good recovery. Now, on examination, what we saw is that there was a lot of edema of the gums on the right side upper teeth. There was some pocketing around this area. And the interesting thing was that if you explored these pockets, there was a lot of loose mucosa and what looked like necrotic bone underneath around these teeth. So we did a few investigations. We did an OPG for this patient. The OPG was pretty much unremarkable. We couldn't really see, there was no obvious dental infections around the teeth, no periapical lesions. But the interesting thing was that there was mottling of the bone in the maxillary alveolus. And if you see this cone beam CT, you can see that there is thickening of the sinus lining. So that made us suspicious that this was probably an osteomyelitis of the maxilla, possibly involving the sinus as well. So a diagnosis of right maxillary osteomyelitis was made. So at this stage, we weren't really doing many general anesthetic operations still because, post-COVID, facilities were restricted. So this was treated under local anesthetic. And basically, we took out the teeth. And when we took out the teeth, you could see that the bone just looked non-viable, necrotic. So we raised a mucoperiosteal flap, and the bone just separated off. With a periosteal elevator, the bone just came off. And you could see, the defect after the bone was removed. There was thickening of the sinus lining. What you can see here in the second picture is the thickened sinus lining. And we curated out the sinus through the same approach as well in order to get drainage. And got a fairly good primary closure. The patient himself made a fairly good recovery. The tissue samples that we sent off for microbiology, and we did grow some fungal hyphae. We treated this patient with amphotericin, and he was doing quite well, but the wound eventually broke down, which often happens when there's a large exposure of the sinus, and eventually we had to give him a healing plate. So at the moment, he still has an oroantral communication, but otherwise it's granulating well. So that's, how he is right now. This is his post-op OPG. You can see that most of the bone looks okay. It's healthy. He's made a recovery and healed. The osteomyelitis seems to have healed, but he's left with a low-level right maxillary defect. He has oronasal regurgitation, and one of his problems is nasality of speech because he's 32 years old. He has to get back to his office, and speech is one of the problems that he has. So, Jacob, do you want to take over? How would you rehabilitate him? We haven't rehabilitated him yet because he's still in a healing process. But
Yeah. So again, as Dr. Anjan had mentioned, some of the cases that the rehab cases are representative cases, and this is one such case. You can see here that this is another patient for whom the debridement was done. The problem with these cases is that we are not able to do a skin graft, do a skin lining, and what that does is it gives us very poor quality epithelium, in the defect, and we are not able to engage those areas aggressively to give a good obturator. The problem with that is then that all the load that goes onto the teeth, and eventually we may start have problems with the abutment teeth holding the prosthesis. You can see here two separate cases. Both are almost similar. In one of them, a skin lining has been done, and you can see how nicely you get a skin graft mucosal junction. And once you get a skin graft mucosal junction, that will help you to support, stabilize, and retain the obturator prosthesis. In a COVID case, you would get a defect which is somewhat similar like this or even larger, and it will not have a skin graft mucosal junction. And what will happen, of course, is that you cannot take much support, stability, or retention from this defect. So what happens then in the final obturator is that you get two types of defects. One is a favorable kind of a defect, and one is known as an unfavorable kind of a defect. In a mucor case, you would get an unfavorable kind of defect because there is no skin graft mucosal junction, and because of that, you will have to aggressively, plate the lingual or the palatal portion, and also if you see both of these, you can see that the number of retainers that are there on the unfavorable defect are much higher than what is there on the favorable kind of defect. So that is one difference that will be present between the two. So this is a representative case. You can see here. I suspect that the defect that we will get with the defect that with the patient that Anjan showed would be something like this without a skin graft present. And you can see here, we take alginate impression and fabricate the framework. We do a final impression, and then you can see that you get a good master cast here where you can engage the defect. This is the prosthesis, the trial in position. This is the final prosthesis that we get. This is how you check to see whether whether there are any overextension present. This is basically zinc oxide paste and Vaseline mixed together, or you can use light body rubber base. And now, of course, use light body more than I use this combination. This is the obturator prosthesis in position. And this is the patient without the obturator. You can see that there is no lip support here at all. And this is with the final prosthesis in position. So this is how we would like to rehabilitate our patients. Of course, not every patient can afford a cast partial denture. And in those patients, we will do an acrylic prosthesis with our regular C class. So over to Anjan for the next case.
So this is another patient who we saw. Again, this patient was diabetic, had been treated at the hospital, and he had been referred to us basically because he had had spontaneous exfoliation of bone from his palate. And this is how he presented. Sorry for the quality of the picture. We just had a mobile phone that day but it was an interesting case, and we decided to take a picture. And you can see that there is some exposed bone, both along the alveolus and the palate. And at that time, the anterior teeth all seemed to be in fairly good condition. There was nothing wrong with them. But knowing the history and looking at the condition of the bone, we understood that this patient probably has maxillary osteomyelitis as well. And the sinuses again did show presence of sinus thickening. And based on this, we decided to take this patient to theater and debride some of this necrotic bone. So we got his diabetes under control because he's a poorly controlled diabetic, and then subsequently got him fit enough to have surgery. This time we did this under general anesthetic, and I'm glad we did this under general anesthetic because when we raised a flap, basically the whole maxillary alveolus just came out in one piece. I'll show you the specimen in a moment, but that is the defect that we were left with. So all the maxillary alveolus, or the base of the nose, the maxillary sinus, all of this just came off in one piece, and that's the defect that you can see with the nasal septum and the turbinates visible there. So again, this is like a low-level maxillectomy defect. The patient, we basically packed the defect with some BIP gauze and gave him a healing plate, and we then put him on liposomal amphotericin. His diabetic control improved, and he made a fairly good recovery. So that's the necrotic bone that we've removed. You can see there's a large amount of bone that we had to remove. All of the alveolus had to be taken out. But he eventually healed well. He made a good recovery. So the challenge that we had was he has a large oronasal communication. There is no bone for placing conventional implants because how else are you going to retain an obturator in this patient? And therefore, we looked at other alternatives. And so we rescanned him. And the zygomatic bones seemed intact, and there was no involvement of the osteomyelitis of the zygomatic bones. So we therefore planned him for a quad zygoma, 4 zygomatic implants. And those of you who know the Zaga classification, this would be a type 4 Zaga. We're basically engaging only the zygomatic bone. There is no alveolus here to engage. And subsequently, we were able to dentally and orally rehabilitate him. Let Jacob take over from here.
Yeah, so we waited for 3 months for the implants to osseointegrate, and we went ahead and placed impression posts on the multi-unit abutment. We joined them together with this resin inlay light cured material, and we took a final impression for the patient. These kind of cases are quite tough to treat, and they require a pretty high level of expertise. So each one of them is actually a learning experience. So we went ahead and fabricate a header bar for him, a milled header bar, and we can see in the final denture, you can see the clips that we placed and the final denture in position. However, and this is the the OPG of the final process is in position. However, 5 months later, the patient came back to us. He had broken the bar. The problem is that all the load of the processes of biting is down on the bar. And I think the mistake that we made was to make a very thin header bar, which could not handle the load, and ultimately it fractured. Another, by accident, we actually kept the final cast with us, and that was really a godsend to us. But what we did in this case is we sent it over to the lab. The lab connected the impression copings together and sectioned them in 2 parts. And also made a very well-fitting special tray. Now, this is very, very important. We need a good, well-fitting special tray, which we did not have in the first impression that we made. So you can see the special tray on the model and the special tray in the mouth. You can see we have the impression ports have been placed in the mouth, and then we went ahead and connected them together in the mouth. The advantage of this is that it reduces the distortion that happens. There is always some amount of distortion, some amount of shrinkage that happens when you connect pattern resin together, and the larger the amount, the larger will be the distortion that is there. Also, it's very important to place pattern, to put tray adhesive on the tray. You need something to bond them together, and then you go ahead and record the final impression. I have a small video that I have recorded of this procedure, and I would like to thank Dr. Divya, my associate, for having recorded and compiled all of these videos that we are going to see now. So, Roxanne, can you please play the video? It's a short 2-minute video. Yeah. So we have seen this. This is a special tray that we have. You make it on the model. You check, you check them and you splint them in the mouth. Then you go ahead and record the final impression. Normally, I use light body and medium body. This is checking the special tray in the mouth. Applying the tray adhesive, which is a very, very important step that we have. Then you go ahead and we need 2 guns with us. In one gun we load the light body, and that light body is injected around the impression port, as you can see here. Then my associate Dr. Divya loaded the special tray with the medium body, and a sufficient quantity of the medium body needs to be loaded. The other thing is that we need to do trial runs of this. Do not try to do it without doing multiple trial runs in the mouth. Once you do multiple trial runs in the mouth, you can actually place it quite easily. Then you go ahead, allow the material to set, remove the impression port pin, and then you go ahead and remove the impression from the mouth. So custom tray is absolutely vital in making an impression. Okay, let's move ahead. Can we go back to the presentation, please? Yeah. And then, of course, we go ahead and make a verification jig for the patient. We do a jaw relation and trial for the patient. This jaw relation and trial is done to allow the lab to know how much of space they have to make the bar. Okay, that's very important, because if we don't do that, then the lab will not know how much of space that they have. So you can see here, this is the final bar that was made. It was actually designed on exocad, but unfortunately we could not mill it on the exocad. So we have made a ball and O-ring attachments. And the difference that we did this time is we made the bar about 5 millimeters thick. So we are hoping that with the thickness of the bar, we will not have a fracture of the bar. This is the opposing part, which contains the clips in position, and this is the trial with the denture. This is the bar, and you can see after the final process is made how it looks, the intaglio surface of the denture. And this is the processes in position. Can you play the next 2 videos, please, Roxanne? So we have 2 videos. One of the patient with the without the processes, how his speech is, and one of with the processes, how his speech is. And he's a lawyer, and therefore it is extremely important for him to be able to speak coherently. There is no volume.
Waiting for claim form. Vishnu Datta Sharma, President of the BJP's Madhya Pradesh unit, recently
sorry about that. There's no volume in the. Anyway, his speech was extremely coherent after this. Since he's a lawyer, that's very, very important. So this we have just delivered it just before the lockdown, and we are keeping our fingers crossed that there will be no further breakages in this process. Can we go back to the presentation, please? Okay, Anjan, back to you.
Yeah, so as Dr. Jacob was saying, I mean, these patients, when you're treating them, you not only the patient, but as clinicians, we also need a lot of patience in treating them, because they're not straightforward cases to treat. Okay, so this is the last patient who we wanted to discuss. So this patient was referred to us by the neurosurgeons. She had been admitted under their care. 74-year-old lady with diabetes, who was 4 weeks post-COVID, who had developed this large area of necrosis on the face and a proptosed left eye. And they had scanned her, and let me just use the marker to hopefully show you where. Can you see my little mark there? So that is actually a brain abscess. This is what a brain abscess looks like. The CT scan in the middle. This area which lights up on the MRI scan. So basically she has an abscess which is formed because of infection of the maxilla, the midface bones, which is tracked behind the eye and has now caused a brain abscess. Basically this lady again needed debridement. There was no vision in the left eye. So we knew that that is something that we may need to treat at the time of surgery. We basically took her to theater to debride the maxilla. But at the time when we debrided the maxilla, we found that all the bone going up to the orbital floor and beyond that, the muscles of the orbit as well were all necrotic. And the last picture that you can see above shows we had to take out her eye. So we had to take out the left eye and the contents of the left orbit. And she ended up staying in ICU for about 2 weeks. She's 74 years old, diabetic, post-COVID. We didn't actually expect her to come out of ICU, but she actually made a fairly good recovery. And this is her 3 months later. The defect that we had to take her back to theater a few weeks later once the infection was cleared in order to cover the defect on the inside. So we had to put in a temporalis muscle flap, because the risk in these patients is because their base of skull is exposed to the oral cavity, the risk of oral infections reinfecting the base of skull and causing meningitis. So we put in a temporalis muscle flap. The muscle flap also covers part of the maxilla as well. So you can see in the last picture there, that is muscle granulating in the oral cavity, and that is sealed off most of the oral cavity so that she is able to swallow without having any significant nasal regurgitation. But the issue, obviously, in the long term for her is going to be, what do we do about her aesthetics? She's missing an eye. How do we rehabilitate her and give her a prosthesis? So we brainstormed about this, and this is her CT scan. You can see that there is very little bone. There's no zygoma here. So conventional implants, including zygoma implants, are out of the question. So how do we plan to rehabilitate this lady? Because she is now fit and well, walking around, and she wants to get back to her life, and she wants something to cover that prosthesis. Now, in these cases, it's very difficult to get an orbital prosthesis which will retain there. You can use things like tissue adhesive, but in our country with sweating and all of that, tissue adhesive doesn't work very well. So for a similar patient, because this lady, we haven't yet rehabilitated her. She's only 2 months, since we did her last surgery and recovered. But for a similar patient with an orbital defect, me and Jacob have treated them with subperiosteal implants. Some of you may remember subperiosteal implants from your dental implant history teaching. They're basically implants which don't go into the bone, they sit on top of the bone. And nowadays we have customized solutions where we can create these implants based on the patient's scan, and they can be fixed with little plates and screws like what we use for fixing our fractures and osteotomies. So for this young girl, we had designed some subperiosteal implants, and these were placed on the maxilla and the orbital rim for her, and magnets were placed into these receptacles, which you can see in the middle slide, the magnets were then used for retaining a prosthesis. So Jacob, you want to take over? And
yeah, so we went ahead, we had magnets and keepers, and we onto the keepers we had to solder some metal pieces so that it will retain. This was the first time, of course, we have done something like this, where we have used subperiosteal implants. You can see here, this is the final wax pattern that we did, and also you can see how the keepers are there in the wax pattern, so to help us position it properly. A customized mold had to be fabricated for the patient because none of the conventional flasks were big enough to pack the silicone. You can see here how we have most of the coloring for this girl was done intrinsically. The advantage of intrinsic color is it is present inside the silicone, and therefore the color will last longer. If it is only extrinsic color, then especially in climates like ours, the color will fade away in a very short period of time. And these processes are not cheap to make, and therefore, we need them to stay as long as possible. And here you can see how the rough periosteal implants are present with the magnets seen. So you can see how we have we matched the color for her. And this is the final processes that we fabricated. You can see the eyebrows. The eyebrows are actually her own hair, and the hair has been taken from her head, and it has been placed inside. And in fabricating this processes, Mr. Gibran, ocularist, also helped us a lot in doing this. So you can see this is the final processes that is there in her, and so far it seems to be doing well. I think Anjan, you can take over.
So fungal infections is one spectrum of the picture of post-COVID problems that we are likely to see. But as dentists, we know most of us are used to treating dental infections. Now, because of COVID, because of the immunosuppression that some of these drugs cause, and the lack of access to treatment, some people just being scared to come in for treatment, we are seeing a much larger number of severe space infections from dental cause. The last lockdown in March, April, we had at least 2 or 3 life-threatening space infections. This is one of them. This was a 61-year-old diabetic, not having had COVID, but just having pain in his lower molars, not being able to see a dentist, given a phone advice to take Augmentin, and after 5 days presented with this large swelling, difficulty in swallowing, difficulty in opening his mouth. And you can see from the CT scan, he had a large lateral pharyngeal abscess compressing his airway, compressing the vessels in his neck, and he ended up needing drainage and subsequently, stay in ICU for a day and, hospitalization. So we are seeing a lot more of these more severe dental infections because of lack of access and, because of the immunocompromise that COVID causes. The other problem that we are seeing is that a lot of patients post-COVID, their general risk of complications increases from any sort of surgery. And this is a paper from the Lancet which illustrates that there's probably a 20% greater risk of post-surgery complications from COVID. Things like increased chest infections, embolism, because patients who have had COVID, their D dimers are raised, they are prone to thromboemboli. They may have cardiac issues, like they may have greater risk of myocardial infarctions, and the problems of wound breakdown and infection locally that we see because of, again, poor vascularity, immunocompromise, etc. So these are just some of the problems that we are likely to face over the next few years, possibly, where we enter into a new phase of managing patients post-COVID. And just to summarize, what we've discussed in these 2 lectures, I think as dentists, what do we need to remember? First of all, we need to collaborate with our other colleagues. Patients, may have symptoms which may be related to COVID, may be related to osteomyelitis, which we're not usually familiar with. Taking a history probably will become much more important. Most of us, many dentists are used to not asking a history before you get the patient on the chair. I think screening for patients is going to become more important, taking a careful history, particularly with these patients having a history of diabetes, of using steroids, immunomodulators, having been ventilated or having had oxygen. These are some of the risks that we need to ask the patient about. Patients may present with all sorts of symptoms. The ones to look out for are the ones in red here: the sinus headaches, stuffy nose, complaining of blurry vision. These may be signs of sinusitis extending upwards towards the eye. Loose teeth or dental pain, this may be a sign of maxillary osteomyelitis, or palatal necrosis again, or discoloration of the gingiva mucosa or the skin. All of these may be signs of fungal osteomyelitis. So as dentists, we need to keep a high level of suspicion, and if in doubt, further investigate these patients to see if they are developing fungal sinusitis or osteomyelitis. Finally, as far as treatment, these patients need good sugar control, they need surgical debridement, and they need treatment with antifungals. Now, antifungals, as Vinay was discussing, the problem in our country is that patients are very good at self-medicating themselves. And already I have had patients calling and asking me, oh, I am recovering from COVID. I've seen all these articles on Mucor. Should I just take a course of antifungals? And I suspect that we are going to see a lot of people self-medicating on antifungals. And the concern is that some of these patients will come back with osteomyelitis, fungal osteomyelitis, which may become then resistant to amphotericin and posaconazole. And, that's always a worry that we have. So that's about it. Any other points you want to make, Jacob, before we finish?
I just, would like to inform all my dental and prosthodontic colleagues that in the coming weeks and months, we will be called upon to rehabilitate a lot of these, post-COVID, mucormycosis or, the other fungal infection cases. And I think we need to be up to the challenge. It's scary sometimes when you actually see some of these patients. And I remember when, especially when we saw Garima, I was quite, I was wondering how we were going to rehabilitate her. And so I think, working as a team is very important. I'm very fortunate to work with people like you and Vinay and, so many other excellent surgeons that I work with. So I would encourage all the dentists and prosthodontists out there to try and work closely with all your surgical colleagues we need to rehabilitate these patients and get them back to at least a relatively normal, outcome, so that they can go back and start living again.
Yeah. Okay, Nupur, over to you.
All right. The audience can type in your questions now. Thank you, Dr. Anjan, for your wonderful talk. You've done some beautiful surgical cases, and there's so much surgery lovers can learn from you. So thank you, sir, for sharing your expertise.
Thank you.
Thank you, Dr. Jacob, sir. It's always a pleasure to listen to you. And you've done some life-changing rehabilitations. When there's facial disfigurement, there's so much of psychological and social impact as well. So I think, thank you for tirelessly working in this field for so many years.
Thank you so much.
All right. With this, we now begin our Q&A sessions. We begin taking your questions. Okay, Dr. Vinay, yes, you're on screen. Okay. The first question, Dr. Raj. Hi all, a wonderful session. You have handled COVID positive patients. According to you, was there any oral symptom common to all? Were there any surprise cases? How was your experience? Dr. Vinay, can you answer this?
You're muted.
Yeah.
Okay. So my experience, when I tell you, I have had experience in 2 countries during this COVID pandemic. So the first half of it was in Sweden and the second half of it in India. In Sweden, it was all clear that only if there were emergencies, and I think that's the same thing out here, if there were emergencies, were you were you going to go in and look at COVID patients? So I was in a university, tertiary care university hospital, so it was only cancer patients, it was major trauma patients, and we didn't go around looking inside the oral cavity to find COVID symptoms. Similarly, in India, I'm right now attached to a cancer center, and where we do only cancer patients per se, and not do regular screening, oral screening of COVID patients. I think regular screening of oral patients are limited to COVID hospitals, where you have to have an ethical committee clearance to just go in looking for those oral lesions. And I don't think there's so much amount of benefit. If you look at risk to benefit ratio, if every dentist goes around looking at COVID patients' mouths and the potential it can cause to propagate the infection, the risk is far more than the benefit. So I think oral lesions have got very limited diagnostic, prognostic value in treatment of COVID patients. That's my personal opinion and experience. I don't know about the other panelists if they agree.
Vinay, I think I would agree. I mean, as far as experience, I've had a few patients who I've treated, and they've probably ended up becoming COVID positive within the week when I treated them. And I wouldn't say that I have seen any, particularly diagnostic features.
Dr. Anjan from Dr. Borse, is fungal infection treatment to remove the lesion, to remove mucormycosis? Is that the only treatment, to remove the lesion?
So, fungal osteomyelitis, generally the source is from the sinus rather than the teeth. So that's what it seems like, at least in most of these patients, is that the fungus probably harbors first in the maxillary sinus, and then secondary to that, probably because of the disruption of the blood supply to the lining of the sinus, you then get an osteomyelitis. So as far as the teeth, I think we would remove the teeth which look obviously involved, where the bone around the supporting teeth is necrotic. Now the problem is that this bone doesn't have a blood supply, so no amount of antifungals is actually going to get into the bone and treat the problem. Yes, antifungals are important, but to reduce the load of the antifungal, of the fungus, I think only debridement is the only way of reducing the fungal load. You're not going to clear. The second thing is drainage, because by removing the teeth and creating an oronasal communication, I know it's a problem for the patient, but many times what you're doing is you're establishing a pathway of drainage, because the sinus osteum itself is blocked in these patients. So there is no natural drainage from the sinus itself. Now for the mild cases, in fact the first one I didn't put up, we do ask our ENT colleagues to come in and actually endoscopically remove some of the disease and create a drainage. But for the larger cases, we end up having to remove the maxilla, and that itself creates the drainage. But yes, surgery, I think, has a very important role. I don't think you can treat these only with antifungals. I don't know whether Vinay
since you're talking about...
I absolutely agree, because the dead necrotic bone and the foci of infection has to be surgically debrided. But at the same time, these patients generally have some form of underlying systemic disorder. So it's just not a surgical management, but also, like with our other colleagues, treat medically. And amphotericin B, that has to be having its own, you have to check the renal status all the time, and so on and so forth. So it's better to do it in a multidisciplinary setting.
So since we are already talking about antifungal medication, Dr. Anjan, is there any, what are the precautions or preventive measures that can be taken to prevent mucormycosis? Can we prescribe them these medicines to prevent?
At the moment, I would probably say no, because we don't know how many of these patients will develop fungal osteomyelitis, and to just treat everyone who's post-COVID with antifungals is probably not a great idea. Again, should we investigate all these patients for fungal osteomyelitis? It's a bit like doing HRCTs for every patient who has COVID. It's cost unproductive, and at the same time, there is radiation involved. So, but I guess probably that is the reason why having a high level of suspicion and making sure these patients get examined by someone post-COVID to rule out, an osteomyelitis early, I think is probably would be my opinion, the best way to prevent these from, getting extensive, where patients are losing eyes and developing brain abscesses.
A question for Dr. Jacob by Dr. Rohit. What does a general practitioner need to take care of while treating such patients? Basically, what can general practitioners do, sir? When do they, at what point do they refer to a specialist, and how much can general practitioners do on their own?
Is the question asking what precautions we should take when treating COVID, or when are you talking about if you think it's a mucormycosis, then
Yes.
what we do?
Once the practitioner thinks that he has already got the disease, then
So
what care can he take while treating such cases, or should he attempt, and how much can he attempt, and when should he refer to a specialist?
No, I think mucormycosis is out of our realm. I think a team which comprises a maxillofacial surgeon and the other specialists in the hospital is required. So, as a general practitioner, if we suspect that it could be Nupur, I think we should refer them out, especially to our, especially to our maxillofacial colleagues. And I think they can take it up and get the rest of the specialities involved.
Question from Dr. Anil. What is the proportion of invasive fungal infection in COVID-19 patients? Is it primarily seen in patients on ventilator? Does oxygen level interfere with this? Dr. Vinay can answer this.
Yeah, so what is the percentage of, there's that paper which is done by a British group on autopsy specimens, and they saw that 10% of their patients had some form of invasive fungal infection on autopsy. So I don't think it is ethical to, I don't know how is it possible to randomly check histology specimens, because the diagnosis of invasive fungal osteomyelitis, invasive fungal infections is through histology. And so histology you can only get in autopsy. And autopsy studies that show are quite rare. But there is a British study which said 10% of the patients had some form of invasive fungal infection on autopsy.
So is there any preference for mucormycosis in adolescent patients, 16 to 25 years of age?
No, I think the youngest patient reported in the literature is 40 odd. So the age range starts from 40 to, for rhinocerebral, right? I mean, you're not talking about the other disseminated hematological. You're talking about maxillofacial manifestation.
Yes, yes.
Am I right?
Yes.
Yeah, so that's, I think the youngest is about, 44 or in the 40s.
Okay, right. Question for Dr. Anjan and Dr. Jacob. Question from Dr. Avi and Dr. Swati. What is the timing to operate after discharge from COVID? And how long should we wait to rehabilitate after debridement is done? So after the patient gets COVID and he has a lesion, for how long should you wait before operating for it? And after you've operated for it, how long should we wait for rehabilitation?
As far as after COVID, the hospital guidelines that we follow are at least 28 days. We don't operate them for 28 days. Obviously, some of them may develop chest problems and things like that, which may make them unfit. And that's the reason why the 28, plus the risk of, others getting COVID in the first 28 days is the highest. So I think that we have operated on some patients post-COVID, and all of them, we've operated on them after 28 days. Fortunately, we've not had any significant morbidity, although one patient did develop a pulmonary embolus post-surgery. This is for a tumor, because obviously with a patient with a tumor, you can't indefinitely postpone their treatment. Now with fungal infection, you can probably wait a little longer because it doesn't need some urgent treatment in most instances. But I think once the patient is fit, so 28 days, then getting their sugars under control, and I think then, that would be the right time if they need treatment. The last lady that we saw, we operated on her at 4 weeks, basically because if we hadn't operated on her, she had, she had a cerebral abscess, and that was an emergency. But that's probably the earliest that we've operated on a patient post-COVID is 4 weeks. The second part of your question was, sorry, about the rehabilitation, right? So,
Yes.
so what we
Dr.
want to
Jacob.
see is that all the bone is healthy, because you don't want to then rehabilitate it, where if you're placing implants, you placed implants into bone which has still got fungal osteomyelitis. So on an average, we've waited for 3 months before, and at that time we rescan them. The scan gives you some idea of the bone is healthy or not, but also then a clinical decision at the time when you expose the bone whether it looks healthy or not.
Yeah,
3 months.
I think
3 months.
I think for the last lady where you have an extensive defect, I think we can wait for 3 months. But Anjan, if it is a smaller defect, like if you have done it through endoscopic surgery, then I guess we can rehabilitate them much earlier.
Yes, oh yes, yeah. I think something like that. Yeah, if you're not placing implants, I think it's fine. I mean, if you're doing dental rehabilitation, I think so taking support of teeth or mucosa, I think you can go ahead earlier. Yes.
Yeah.
In fact, because this patient already had a healing plate,
Right,
so
exactly.
it's similar to that. So I would say, yeah, as soon as the mucosa is healed.
Yeah, but how much time would you then wait? A month?
Yeah, for the soft tissues to heal, so that you have stable soft tissues to take an impression.
Yeah. The other problem is, of course, how long does the COVID linger? Because now they say that if you take anal swabs, I believe that the COVID is present there for up to 3 months. So even once it gets cleared from the lungs, they are saying that now does that affect us in any way? I think in India they have.
I don't know what the literature says, but at least from an experience point of view, we have operated on a lot of patients because after the first wave, we had a number of patients who had malignancies which needed treatment, and we've had to operate on them within 3 months of them having had COVID. And I don't think any of them have had any significant, or I don't think any of our staff became positive because of treating them.
Right.
I think the paper says after 3 weeks it's reasonably okay to operate. The risk reduces quite a bit.
Yeah.
Dr. Vinay, question for you. I belong to a suburban setup and my patients refuse to take a COVID test before extraction or emergency RCT. Are there any signs I can look for in the mouth which can confirm at least 90% that patient is or has corona?
No, I'm sorry. There's nothing that I would like to say. You could have seen this, but all these oral lesions that you see, it can raise your suspicion, but then it doesn't realistically tell you that okay, if a patient has got an ulcer, oh, he has got COVID. No, unfortunately, we don't have anything like that. And I know your dilemma, and I know if they don't refuse for a test and you have to treat them. Sorry, there's nothing like that.
There's also this similar question by Dr. Rupashri. Please guide on early diagnosis of mucormycosis during clinical examination, as many patients might not reveal history of COVID infection.
Yeah, so I think looking at doing a good oral exam, checking the periodontium particularly, because pocketing around teeth, particularly teeth which don't look obviously in poor health, and developing pockets, or patients who've not had a history of generalized periodontitis suddenly developing periodontal disease. I think that's from an oral point of view. Bone exposed in the oral cavity, like you saw in some of the pictures that I showed, palatal bone exposed, alveolar bone exposed, and history of sinusitis. So, blocked nose, sinus symptoms, and, visual symptoms. Now, I guess if you have an OPG, it may be helpful, but, our experience is, I don't think we've diagnosed a single case of osteomyelitis on the basis of an OPG, because the OPG shows very late changes in osteomyelitis.
Question for Dr. Jacob and Dr. Anjan. Is the treatment approach similar to conventional diseases like osteomyelitis, or is there anything more that we should take care of if patient has a history of COVID? How should we go about it?
I mean, we've treated a few myocard cases. I think both me and Jacob have treated a few myocard cases together even before COVID. And I think the treatment, I mean, honestly speaking, we haven't actually rehabilitated all these COVID patients yet. So maybe it's a little too early to tell. But I think we would probably treat them similar to any patient with fungal osteomyelitis, before COVID or after COVID. Would you do anything different, Jacob, for these patients? I don't know.
No, I don't think so. I mean, like I said, in one of the biggest problems is we can't skin graft these patients, and so then the maximum load comes on the teeth. The problem is if the patient doesn't have good teeth on the opposing side, then it becomes more difficult in treating these patients and giving them a good observation. Otherwise, it do the same.
This is for the oral surgeon, Dr. Vinay, Dr. Anjan. Cytokine storm and its role in prognosis of any surgical procedures. Where do we stand today?
Cytokine storm in the sense interleukin-6 and so on, which contribute towards COVID? Or is it general post-surgical?
How do they contribute towards the prognosis when you are doing a surgery in a COVID patient? Because I think midway through the 14th day, there is a cytokine storm where it peaks, where all these inflammatory mediators are peaking. So does it have anything to do with the prognosis when you perform a surgery in such patients?
I don't know. I've not looked into this aspect really, but I think it's something that's expected. You have a cytokine storm. You have after a particular surgical infection, when you have, intervention, you have these kind of things. So I'm not too sure about this.
When do we get to see COVID tongue? After how many days of COVID infection? And what is the treatment of COVID tongue?
Okay, so there's a lot of this COVID tongue when it first came out by that Bodard et al. They said that is initial symptom of COVID, but that's really not substantiated. They say, like I said in the presentation, that if there are mild COVID lesions, perhaps you see it at the beginning, oral lesions, and if it is severe, then perhaps you see it in between the disease. But these are all not really related to COVID disease per se. So I don't think, in my opinion, after reading through all of this, it's COVID tongue is geographic tongue. So if you have a geographic tongue, like geographic tongue appearance. So if you have a geographic tongue, doesn't mean that it's COVID. Yeah, that's my understanding.
It may just be
an incidental finding or a secondary feature, depending on the systemic condition of the patient. So if the patient is debilitated, then you do have these kind of hyperkeratotic changes on the tongue, irrespective of the disease.
There's also a lot of talk about COVID lips, bluish cyanosed lips when the oxygen level reduces. Did you come across any of this while you're in your
research? There were also a petechiae, so the discoloration can be because of some form of coagulation, intravascular coagulation or bleeding. But the problem is, most of the either they have case reports or case series which say that, hey, I've seen so many cases who have had these lesions on the tongue and they were either COVID positive or they went on to develop COVID. But that's just, so COVID has hit such a large amount of patient population and we are having it as case series or case reports. So that's a very minuscule proportion of patients who have that. If you look at the number of patients who have been affected by COVID. The second is that Others are cross-sectional studies where a group goes into a camp and tries to see what are the oral features. So again, how representative is that to a patient who's walking into your clinic is really questionable.
Right. Okay, this is a personal question for all of you. Look at the situation of our country now. No beds, no oxygen. All of you have been trained abroad. What was the reason that got you back to working in your home country instead of simply settling abroad? Dr. Jacob, we'll start with you.
Yeah, I trained very early, actually, a long time ago. I was in the US in the late 90s. And of course, I wanted to stay back there. I didn't want to come back. But I trained with Dr. Buma. And so the question he asked me was, will you go back and train other maxillofacial prosthodontists in India? And I got a scholarship from the American Cancer Society. It was actually a surgical scholarship. And he managed to wrangle it for me at that time. And he also allowed me to treat patients, which was not done. So at that time, of course, I was a little bit like, no, I don't want to go back. I want to stay here. But I think, and there are still times when I do feel, why did I come back and things like that. But overall, I think I've had a great career here in India, and I'm happy that I've been able to interact with a lot of people and train some of them. So I think that's the reason why I came back. I came back because I gave my word to myself that I would go back to my country and help to train other people. And the kind of satisfaction that you get when you are treating patients here is amazing.
Dr. Vinay, I think, has recently shifted back.
He's the youngest.
Yeah, I've still got one leg here and one leg there, but that's how I manage most of. So I think there are benefits in both. So for clinical practice and for patients, the challenges that we see and the pure excitement and what you can contribute towards the science as per se, clinically, I think it's much more in India. And yeah, all the quality of life. For example, if you look at quality of life, saying that, oh, everyone's got clean air, water, so on. The standard of life, you feel you belong here. You don't feel that you belong in another place. So that sense of belonging to a place, that's more important than, I think, financial remuneration. But I still keep my university attachment simply because they have all the equipment, they have the funding, they have things which we can't do out here. So I think it's a good mix between both worlds. And yeah, I like it here. Maybe after some time I get bored out here, then I go there, and I get bored out there and come here. So I don't know. Yeah.
I just want to make one more
Dr.
point.
Anjan.
I just make one more point before Anjan comes in. The other thing is, like Vinay says, you never actually belong, there. I mean, you always feel like an outsider. And also, I get to work with brilliant surgeons. See? I get to work with Vinay, with Anjan, with Moni, So I actually asked Moni once, and Moni is like one of the most, he has taught all of us, literally. And he said the kind of satisfaction you get in India, you don't get anywhere. So I think that was the main reason. Anjan.
So, I think if you look at the health systems, first of all, most of the Western countries, you have a managed health system. So you go into a job, you go with a specific area where you're supposed to work. And it's very actually difficult to move out of that and say, okay, look, I want to do something different, and can I do this because I'm interested in it? It's very actually difficult to get out of it. It's a very structured system, which is good for training, I think. And I think the training that I have had in the UK was exceptional. But at one point, for example, I trained to become a reconstructive surgeon. And then 5 years later, they decided to move the cancer services from the hospital where I was working to another hospital. And I would have had to then, become an oral surgeon, taking out wisdom teeth and treating fractured mandibles. And I, decided that, after having trained for 10 years doing this, it would be a waste of my skills. Obviously, then, you have to balance the two, which is, finances, your work, and or in a family life, all of this. So I think the decision is probably different for different people. But I'm from Bangalore. My family was here, and I think having come back, I think financially also, I don't think I'm doing that badly. I think one probably note for the youngsters is, for example, me and Jacob, I mean, we treat these exciting cases, these maxillofacial prosthetic cases, but we actually make very little money out of these patients because most of these are not affordable. They've already exhausted their resources treating their tumors and all of this. But at the same time, we have a large practice of regular conventional implant patients to balance out. So I think we make enough to, go home and, enjoy ourselves as well.
That's great. All right. Question for Dr. Jacob by Dr. Chetna. How to rehabilitate patients in which the surgical removal involving complete maxilla and zygoma is done and closure is with soft tissue to separate the oral and the nasal cavity? So already a flap is there. So how to rehabilitate?
Unless one of the surgeons can give me some implant support somewhere, not possible.
Difficult.
I think this is
impossible.
I think this is the problem we face with Garima, isn't it? That we just didn't have a zygoma to support. So I think the subperiosteal implants, I think they are being used much more. We have very little experience with them yet, but I think if you look up the KLS Martin website, KLS Martin is a company which does a lot of customized implants in Germany, and they have quite a large series of subperiosteal implant rehabilitation for cancer patients. I think that's probably one solution in the future which we may be looking at as a solution to these problems.
Possible. See, KLS Martin and all, we can't even go near those implants.
No, I think we just have to indigenize them like we did for her. I mean,
for her, I guess so, something like that. See, unless I can get some implant support, with a framework of some sort, it's next to impossible to try and, to. What about the fibula for some patients like that? Is it feasible at all?
Yes, I mean, fibula is a possibility, and it's a good option.
Yeah.
But I think the question was that she's already had a flap. The problem is, how many of them are willing to have further surgery, and some of these patients are not fit for a microvascular flap. After, they've had radiotherapy to the neck, then finding vessels. All of these are issues that we sometimes end up facing with doing rehabilitation with fibulas.
What about Vinay? Have you had any experience of this in Sweden?
Of
like a bilateral maxillectomy, no zygoma with a fibula reconstruction?
So this individualized titanium printing, additive manufacturing of titanium, Sweden was one of the first countries to get into this. In fact, Uppsala University along with Sundsvall, they had started it about 15 years back or something with cellular studies and so on and so forth. But it's really expensive, and the numbers are very low. So they get one case perhaps in the country, perhaps in a year or something like that. So we don't have clinical data so much. If you look at most of the time, they're all preclinical data of all these subperiosteal implants from Sweden.
In fact, I had gone to Uppsala about 10 years ago, and I met Vinay's predecessor, Jan Hirsch. He had shown me a printed mandible, and I always said, this will never work. This will never become practice. But we have done a subperiosteal implant since then. So I think these things do eventually get into clinical practice with a few modifications and refinements.
Yeah, but especially, of course, there should be no radiation involved, right? At all.
Yeah, I think that is an issue. Yeah.
Anyway, I think we are diverting from COVID right now.
Coming back to the basics, radiography. What are the radiographic features of mucormycosis on OPG? Question by Dr. Shruti. radiographic features
So,
of
should I?
mucormycosis on OPG.
Yeah, Vinay,
OPG,
Dr.
you cannot make out actually. You can't clearly differentiate from one osteomyelitis as to other. You can have this radio opaque kind of cloudy kind of thing, but other than that, I think OPG is quite poor because most of it is maxilla in mucor and not much of the mandible. So a CT would be more beneficial. And in CT, like Dr. Anjan had shown in all the cases, the CT findings, like kind of moth-eaten, there will be some soft tissue swelling, some areas for sinuses like lucencies, total lucencies, sclerotic borders, and so on. Dr. Anjan, you'd like to complete?
Yeah, I think, see, primarily this disease starts in the sinus, I think, from, what I've seen. Because all of these patients, I mean, the teeth weren't in particularly bad condition. So I think the initial, in most of these patients, is from the sinus. So seeing sinus disease is the main factor. Now, an OPG is not a great tool for looking at sinuses. You might see some opacity, like Vinay said. In fact, my treatment of imaging of choice would probably be a regular CT rather than a cone beam CT, because even a cone beam CT doesn't always show the soft tissue component very well. So the advantage of a conventional CT is that it will show the soft tissue, particularly if you're looking at extension into the ethmoidal sinuses and things like that. I think it's sometimes not, cone beam CT may not be even large enough in terms of volume. I mean, there are larger volume CTs now, but it may not show the full extent of the disease. So I think a conventional CT would be my number one imaging. If that's not possible, then I think cone beam CT. But OPG, I don't think really has a great role. It's probably good for ruling out dental disease, but for actual osteomyelitis, probably not much.
Dr. Supriya is asking, are patients with periodontitis who develop COVID-19 infections more susceptible to severe disease? Dr. Vinay?
Yeah. Periodontitis is susceptible to all kinds of diseases. Premature delivery, stroke, all diseases, you name it, and periodontitis is associated. But yeah, COVID also. I think there's a recent German study which came and said that patients with poor oral hygiene and periodontitis have poorer outcomes in the disease as compared to healthy mouth. So yeah, naturally your mouth has to be healthy.
So for keeping this periodontal health intact, do you think any mouth rinses help in prevention, like betadine mouth rinses, or there's this stabilized chlorine dioxide, which is said to be reducing the viral load of COVID-19? So do you think they have a role to play, and if they do, then how frequently should they be used? Dr. Anil has asked this question, and Dr.
I think Dr. Jacob he was looking at his clinical practice and the mouth rinses. He did a lot of study on that, I think.
Dr. Jacob.
I didn't do any study. I saw one, there was one article that I got, I think it was it was in the British Oral and Maxillofacial Journal, where they said that, I think I shared it on the group, that all of these mouthwashes have some role to play, but none of them were conclusive. They said it is good for 1 minute to gargle with them, 30 seconds in the mouth and 30 seconds in the throat. And they said any of these, chlorhexidine, providine iodine, hydrogen peroxide at the various concentrations. I don't have the concentrations with me. And stabilized chlorine dioxide, any of them can be used or should be used. But they did not say whether, my major concern is, okay, patient rinses out, with all of this. What about when the patient swallows or something? What happens to it then? Do we lose the effect of all of these mouthwashes, or do they still continue to remain? But I don't have an answer to it.
All right. Last 3-4 questions now. Dr. Anjan maybe can answer this. There's a recent mutation of the virus now. Test is negative. Patient may be asymptomatic, but the disease may still be progressing inside. How do we know if our patient has COVID or not?
So I think any patient who comes into your dental practice today, or in the future now, I think one thing is they all need to be screened. So you need to take a history, of temperature, travel, all the various things that we're supposed to do. As I think the guidelines are already there from IDA, various places, but we need to take a questionnaire. And as I said during my lecture, I think we have a habit of wanting to make the patient feel welcome, and we just get them straight into the chair. And I think that's something which we'll probably have to change. We need to take a history of the patient, both of travel, symptoms, their medical history, before deciding, do we want to treat the patient or do we want to refer them for investigation. I have had patients recently who walked in saying, oh, I've been having body ache. I mean, they've come in because they've had toothache, but they say, but apart from that, I've also had a fever and body ache, and I've referred them off, and they're COVID positive. And I've just taken a history. I've not actually seen them because of the risk. So I think we need to take a careful history and then decide, do we want to see the patient or do we want to defer treatment? That I think has to become a practice. As far as testing, I don't think really there is I don't think it's practical in the long term to test every patient. Especially when you have multiple appointments for a patient, especially, for example, to treat patients which Dr. Jacob treats, they come in 3 times, 4 times for treatment. Are you going to test them each time they come in, for a jaw relation, for a teeth trial, for a retrial of the teeth? Are you going to test them each time? So I don't think testing is really a practical solution. I think we just have to follow universal precautions. So, the cap, mask, scrubs, PPE, I think is probably a safer thing than trying to investigate them and screen patients. I don't know what Vinay, Jacob, what your take is on that.
Yeah, I agree with Anjan, especially where multiple appointments are required. I think just like we have, universal precautions for things like HIV, I think we will also probably have to do the same. Yeah, I don't wear full PPE because I just cannot work with it. It's not, it's not something that I tried, but I can't work with it. So I just wear a surgical gown. And then I wear an N95 or FFP2 mask. And then maybe we can add on a surgical mask onto that, which we can change after every patient. Then wear a head cap. Again, I'm not comfortable wearing a visor, so I wear goggles. I guess, make the patient do the mouth washes. If like, I think we have to start taking more detailed histories. I'm also at fault in, taking my patients straight to the chair. I think that is something that I need to stop. And if the patient complains of any kind of symptom like fever or, any of the common symptoms, then I would say, okay, please get a COVID test done and come. The problem is the patient comes with, severe toothache. And then you tell the patient, go and get if he says, okay, I've also had, fever. Then if you tell the patient, go get a COVID test done and come, I don't know how far, something like that is feasible. So there are no hard and fast rules, but we will have to figure out how to handle these patients.
Dr. Vinay, this new mutant that has come, are the signs and symptoms different in the oral cavity from the normal virus strain that was there last year and this mutant strain?
So if I were to look at this like oral cavity signs and looking for right now, when the public health system is so burdened with even normal treatment, people can't get beds, people can't get adequate treatment facilities. So looking out for oral symptoms in those kind of patients is not, I think, the correct thing to do. If you are suspecting a patient who's got a new mutant symptom, I mean, if he's symptomatic, rather than looking and searching for oral cavity lesions, I would be happy to tell him to stay at home, be isolated. Then if it gets worse, go to a doctor, into a hospital and try and get admitted rather than look out for oral lesions. So I think oral lesions, yeah, the virus the host cells are the oral cavity, agreed, but to look for oral cavity lesions is, I think, putting yourself at a big risk, and the benefit that you get is not as much. That's my understanding.
All right. Okay, now one last question from the audience.
I saw a lady who's Dr. Shubha has said that a case after giving a denture, patient developed swelling under infraorbital region and no irritation from denture and no other cause of swelling, I presume. I think this is a case that you would like to investigate further.
Further.
Yeah, I think you have to get a a CT scan and investigate that swelling. Why is that swelling coming in?
All right, last question from my side. One small take-home message for the audience from all of you. Dr. Jacob, we start with you.
These are difficult times, but we need to get over it. Yes, we are all. My clinic has been shut down for the last 2 weeks because of the lockdown, and it probably will be shut for another 2 weeks because Karnataka is going into a full lockdown. And it is scary. Sometimes we think, we are so close to the patient when we are treating our patients. So, but I think by taking universal precautions, I think we should be fine. If you suspect that the patient has got COVID, by all means get the patient tested. But we cannot overload an already overloaded system by sending all our patients tested. And at the same time, we will get through this. That's for sure. We will get through.
Dr. Anjan, take-home message for general
yeah, I think what we've discussed today, the information we've given, there's still a lot of new things that we are learning about COVID. So I don't think any of it you should take it as gospel, but I think these are guidelines. I think the main thing is, about screening your patients before treating them, taking a history, and looking out for signs of fungal osteomyelitis. That's what, we want to identify. As far as, will our practice change with COVID? See, the way we treated patients before HIV and hepatitis B has changed. Some of us, like probably Jacob and me, have, qualified at the time when AIDS and HIV was just coming in, and people said, this will be the end of dentistry. Especially there was one dentist in Florida who became positive, and people were like, dentistry will never be the same. But we've learned to adapt to it, and I think hopefully we learn to adapt to treating patients post-COVID as well. One of the good things, I guess, is I was reading a paper just today that 82% of patients want to come back for dental treatment, once COVID is over, or when things get better. So I don't think any of us are going to lose patients or go out of work, but I think we need to hold out, and be prepared to make changes to our practice.
And Dr. Vinay?
Yeah, all I can say is stay positive during this tough phase. And then, we'll learn. Every day we learn. So we learned how to deal with the situation. If you don't have the answers today, don't worry. You will have it tomorrow for sure. So just get through with it.
Stay positive.
Yeah.
Collective take-home messages: we shall overcome.
We shall overcome.
We shall overcome this pandemic.
Yeah.
Get back. So thank you, all dear speakers, for sharing your precious time with us and your expertise with us. Very enlightening session indeed. A lot of comments. Your audience has really loved the session, and definitely there are a lot to take away from all of you. A big thank you to our audience as well. You've been very interactive, so thank you. We go off air now, but don't forget, we have another session coming up at 4 p.m. by KSDC or Karnataka State Dental Council, where we will learn how dentists can lend a helping hand to the physicians. So wish you all a lovely day. For more updates, please join the Facebook group. You will get all the information of the session there. Thank you and bye-bye.
Thank you, Nupur, for
Thank you very much. Yeah.
Thank you,
fantastic
Nupur.
moderation, and thank you. We've got a phenomenal number of questions. So thank you
Yes, you got many questions.
for everybody who attended the
Yeah.
webinar.
Thank you,
You almost
Nupur
had
and
1 hour of
Roxanne.
questions.
Sorry.
Almost 1 hour of questions.
Yeah. Thanks. You organized it so well that it I think flew seamlessly. It went quite nice. That was great organization. Thank you so much.
She always does that.
Thank you, sir. Thank you.
Okay,
Thank
Nupur,
you,
thank
and
you.
Thank you, Dr.
goodbye.
All right. Bye-bye.